make the best use of everyone's time. Um, First, I'll start by introducing myself. So, my name is Megan Wardius. I work at the University of Virginia here in Charlottesville, Virginia, and we are the main site for the KESETT study, but we are collaborating with partners all across the country, including the University of Michigan, the Medical University of South Carolina, the University of Minnesota, and many others. So we are so grateful to be part of a wonderful team. I'll also drop in the chat a website that lists all of the different centers that will be participating in KESETT. And so the sites on this list on the website here, their emergency departments will be participating in the study and enrolling patients. Um, I'm joined today by Dr. Jadeep Kapoor, who is also here at UVA. Dr. Kapoor is the lead researcher for the study and has been an epilepsy researcher for over 30 years at the University of Virginia. So I'll run through our brief presentation, and Dr. Kapoor will help add in and answer your questions. Um, we're really grateful for you all being here today, and this is really an informal presentation that's meant to serve you and your community. So feel free to, raise your hand with questions throughout, put them in the chat, or we can, save questions till the end and have plenty of time for that. So whatever works best, we're just really here to speak with you and have a conversation. And then lastly, before I get started, I just really want to thank Gabby and Casey for setting this up and letting us share more about our study with you. So KESETT is a study that is looking at seizure emergencies and treating people that come into the emergency department. And so I know that you all are very knowledgeable about epilepsy and seizures, but just, to briefly review, we know that seizures can affect children and adults, and both of those groups will be eligible to be in the KESETT study. And most of the time when someone has a seizure, the seizure will stop on their own, but oftentimes sometimes seizures don't stop on their own, and these prolonged seizures can be life-threatening, as you know, and that is called status epilepticus. And we also know that the current medications that we have for treating status epilepticus are not good enough. So that's the purpose of KESETT, is to try to improve the treatments that we have available in the emergency department for status epilepticus. So out of every 10 people who have these prolonged seizures, 6 of those 10 will stop seizing after they receive an initial dose of medicine at home, either from EMTs, from their home medications, and these are usually benzodiazepines, right? So that's the most common anti-seizure rescue medication that people have at home. But of the 4 that continue to seize after that, only 2 of those 4 will respond to the next medication that they receive in the ER. So we want to make that better. And these are numbers that are specifically looking at the entire population. So these are not specific to necessarily genetic epilepsies or patients with SCN8A. So in the KESETT study, everyone who's entered in the study receives an active treatment. So we don't have a placebo arm where anyone in the study is getting no treatment or placebo. There are 3 possible treatments in the study, and all 3 of those treatments contain levetiracetam or Keppra. So levetiracetam is in all 3 treatments, and then in 2 out of the 3, we're also adding ketamine to the levetiracetam to see if adding ketamine to the Keppra is more effective than the Keppra by itself. And there's two different dose levels for the ketamine. So there's either the levetiracetam plus a lower dose of ketamine at 1 milligram per kilogram, or levetiracetam plus a higher dose of ketamine at 3 milligrams per kilogram. The reason for this is that we know that levetiracetam is the most commonly used anti-seizure medication in the emergency department. But again, it only works in about half of the people that receive it for status epilepticus. So this KESETT is a randomized blinded study. So the patients, the families, and the doctors won't know which treatment the patient is assigned and received. As we mentioned, we will be doing this study at over 60 centers across the country. So this map is it's hard to see exactly where the centers are on this map, but that list that I put in the chat has more information about which centers are currently participating, and we may expand throughout, but you can you can use that list to find the one that's closest to you if there is one close to you. So who will be included in the study? So people who are coming to the emergency department and having a prolonged seizure that hasn't responded to benzodiazepines. And this would include adults and children who are 1 year old or older. And having a history of epilepsy is not required to be in the study. So these could be people who have had seizures before, or this could be their first time in status epilepticus. So what will happen once they're entered into the study is that the person would arrive to the emergency room and be evaluated. If they haven't received adequate benzodiazepine, the emergency room doctor would order that and make sure they have received enough benzodiazepines. And then they would see if the patient, if they continue to seize, could be entered into the study. They would receive 1 dose of the study medication, and that's allowed to work for 10 minutes. And then if that person is still seizing after that 10 minutes, then their normal care would proceed from there. So the doctors would make the best medical decision to continue treatment for the patient. Our study also involves using a EEG headband that's placed around the head to collect some EEG information about whether seizures are continuing. And in some patients, we may collect 1 to 2 blood samples as well. So when we think about the possible risks and benefits of the KESETT study, the reason the study is being done is that we don't know whether the treatments with ketamine are better, worse, or the same as the treatment with just Keppra alone. So we don't know if by being in the study whether people will benefit or not. But we do hope that the knowledge learned from the study will benefit future patients with epilepsy, and people in the study could benefit. We know that continuing to have prolonged seizures is a risk to patients whether or not they are in the study. And we do also know quite a bit about the potential side effects of the study medications, since both of those drugs are commonly used in the emergency department. So we know quite a lot about the safety of Keppra and the safety of ketamine. Both of those drugs are used routinely by emergency room doctors, but we're trying to learn more about the risks and benefits of using those together. I see some questions in the chat. So, Jadeep, do you want to speak to the question, which is, what is the probability of breathing difficulties with the medications together?
Great question. So, 2 things. Keppra alone We know that the breathing difficulties uh, during seizures and status epilepticus largely come from seizures. Long ago, we used to worry whether to give benzodiazepines at home. But now we've learned that if you treat the seizures, the patients breathe better. Similar was the experience in established status epilepticus treatment trial. So the risk of uh, patients stop breathing is higher from seizures than from the drugs that we've used thus far. Now, Keppra or levetiracetam caused uh, in the ESETT study in adults, 1 out of 4 patients got ended up on a ventilator, uh, and those were the ones who were mainly ones who were not responding to the medication, but not all. Uh, in children, only 8% were ended up on a ventilator when they were treated with Keppra. In contrast, phenytoin or Dilantin, 25% of kids ended up on a ventilator. Uh, Question really is, and we don't know the answer, whether ketamine will cause respiratory problems. Now, ketamine is not known to cause it. There are thousands of patients who've been given ketamine uh, in emergency departments in United States, and we quote those data in our studies to FDA. But all over the world, in Africa and low resource environments, it is common to conduct surgeries under ketamine anesthesia because they don't require ventilator or respiratory support. So all the data until now is that ketamine will be safe. However, we'll be watching the patients very carefully, and they'll be monitored very carefully to look for this, whether they develop any respiratory problems after getting these drugs. So a good question. Question in the chat is with them together, both Keppra and ketamine. We with Keppra, ketamine, and status epilepticus, right? All three things together. Where we don't know, but we'll be watching carefully the patients whether that happens. And uh, all the data, especially about respiratory distress, intubation will be collected on all patients. Megan, I don't know how many CRFs we have on respiration, and it'll be reviewed by an independent board, data safety monitoring board, and they'll keep track of if there is an unusual or unexpected increase in intubations related to ketamine. That independent data board will not be told, but they can intervene and tell us to uh, uh, respond to it. But we'll be watching fairly carefully, and there are detailed instructions to physicians to watch for something happening. But it is not, at this point, we don't expect it, but we're watching carefully.
Thanks, Judy. Casey also made a great point in the chat that we know that many of you many of you know that your child, family member, loved one does not do well with Keppra, and so we can talk about that now or a little later. Maybe I'll go through, how exactly they're entered into the study, and then we can bring this back because we do know that this is particularly important in your community and one of many reasons that we wanted to talk with you today. So KESETT is a study that has been approved both by the FDA, the Food and Drug Administration, and the regulatory groups, the IRB, that oversee clinical research. We have received approval to conduct this study under what's called exception from informed consent for emergency research, or EFIC for short. And so these are studies that are done for emergency research in situations where getting an informed consent from the patient and or their family is not possible before we start the study. And this type of research is only permitted in very special situations. So that includes studies where there's life-threatening situations, where the current treatments are unproven or not good enough, when there is the potential of a direct benefit to the patients who are entered into the study, and when consent is not possible due to the medical situation. So there are several components to doing EFIC research. So one is that if a family member is present right before the research is started, that family member is given the opportunity to decline research before it started. So there's not sufficient time to do a full informed consent discussion where someone could give their permission for a study, because we know that the best practice to really receive a truly informed consent is to allow someone to receive detailed information about what will happen, the risks and benefits, to be able to ask questions, to be able to really think about the study before saying, yes, I agree to something. And even though that's not possible, it is possible to know that you don't want research to happen and to decline that. So that's the first component. We also will proceed with providing the family with notification and more information to give consent as soon as possible after the research has started. So once the um, patient is medically stable and the family is in a good place to receive more information, that will happen as quickly as possible, whether it's in the emergency department or in the hospital. And those conversations will continue between the group that does the study at the hospital and the family for as long as needed, until the family is able to get all of their questions answered and decide whether or not they want to continue in the research. The other thing that's really important for these types of studies is that you are able to opt out beforehand, if you know that you or your child or family member does not want to be in the study. So we don't have a way to opt into the study, but rather a way to opt out. And that involves using medical alerts primarily, to designate that you do not want to be in the study. So we would recommend that you speak with your medical providers and make sure that the medical record reflects the desire to not be in the study. So you can specifically say KESETT declined or KESETT opt out. We also have silicone bracelets that we're happy to send to you that can be worn, that say KESETT declined. And then we also encourage you to have a conversation with your provider about like making sure that the medical record indicates, if there's more information that would be helpful as to why you don't want to be in the study. For example, if you know that your child or family member never wants to receive Keppra, that should be also indicated. We would recommend through a levetiracetam allergy or contraindication, because adding the KESETT opt-out language certainly would prevent you from being enrolled in our study, but would not necessarily prevent receiving Keppra for another reason. And then lastly, I'll just mention that community part of doing an EFIC study is working with the communities to understand the study, and also for us to receive feedback from communities about the study. That's not only a required part of doing these studies from the FDA and IRB level, but also the right thing for us to do is to really educate geographical communities and also medical communities that this study could be happening, and seek your feedback on the study. So That's part of what we're doing today. All of the hospitals that are in the study are also working with their local community to share information about the study and collect feedback. So it's something that we take really seriously. And again, we're just really grateful to be here with you talking about this. Jadip, any comments about that?
Yeah, basic thing. We wanted to. I know that uh, there's guidance that uh, kids with or individuals with SCN8A mutations should not receive levetiracetam, and we want to make sure that all of you know that this study is about to happen, and that if you don't want your loved one to be getting levetiracetam, we think the most effective method is to enter into the chart. Do not give levetiracetam. If we can you even be entered as a allergy. We of course give opt-out bracelets, but because the standard treatment of status epilepticus is becoming levetiracetam, even outside the study, you don't want that person to get lev. So that's what we are recommending. But of course, we can easily give opt-out bracelets. But I wanted to make sure that you all in this community was well aware of the study, and make sure it's not our desire to enroll anyone who doesn't need to be a one to be enrolled in this study. And so that's why, we want to meet with you, let everyone know, and make sure that every child remains safe and uh, not get enrolled in the trial when there was no intent to do that.
Yeah, thanks, Dr. Kapoor and Megan. This was really helpful. And I think, first of all, thank you for taking on research that is helping us find better first line options for breaking seizures, because I think probably just about all of us have spent time in code rooms where our children have not responded. And this is something we need much better research on across the board. I wonder if, and a lot of us have had negative experiences with Keppra, as you've said, and I think it's a great idea to advocate with our clinicians to get it in records and so that it's seen as an allergy potentially. But of course, when we leave home, we leave our health system, and so the bracelets are also a good idea. And I don't know if it's possible to get them for a medical allergy somehow, like a medical alert bracelet potentially, but that's another issue. I wonder, Dr. Kapoor, good to see you, by the way. Hi. If you could talk, a lot of us have encountered Keppra, but less of us, I think, have encountered ketamine use in
Yes.
hospital settings. Is there any research on the efficacy of ketamine in rare epilepsy disorders?
Uh, Not much, but in status epilepticus, excuse me,
Bless you.
there has been research. It's used in when everything else fails.
Mhm.
That's when ketamine has been used for last 20 years now, more than 20 years. It has been used in that setting. And there, the studies, again, those are all open label studies,
Mhm.
and estimates are that approximately half the patients benefit. But we wanted to use it earlier because uh, we think it can be quite effective in earlier stages. There are some case reports coming from emergency rooms around the country that uh, uh, it has been effective. Again, open label studies uh, that have been done. There have been no problems in patients with epilepsy who've been given ketamine for other reasons. It's often used for anesthesia, so they've been uh, at least I'm not aware of any problems that ketamine has caused in patients with epilepsy when used as an anesthetic.
Mhm. I have another question, but I'll let others jump in if they have questions, or if you want to cover this slide, Megan, and then we can go to questions, whatever you prefer.
Sure. Yeah, I'll just go through this real quick. So we did touch on opting out a little bit, but so you can add medical alerts to the record or a bracelet. I know that there's some where you can they have like a chip and you can update them with additional alerts. So that could be an option. But also we have some silicone bracelets that are printed with KESETT declined that you can request using the survey that I just put in the chat, and we can also send this out afterwards so that you have it by email if you don't get a chance to scoop it up here. But we can mail a bracelet directly to you, and that could even be worn like by you, if your child doesn't do well with bracelets, and then assuming that you would be there in the ED. It could be a nice reminder both to you and then to them, the providers for the opt out. And then to the last point. So if you do opt out of the study, you would just receive the normal treatment that for your hospital that they would normally give. And I know many of you have a seizure action plan. And that's a great suggestion, Casey. You can also attach it to a bag or wheelchair, stroller, things like that. Even just carrying it with you might remind you, that this is happening. With that, I think we're happy to take more questions. So please don't hesitate. Put them in the chat or raise your hand or just unmute and ask.
I do have a question. We have some people in our community that have done well with Cupra in the past. So I guess regardless of their genetic mutation, if they've done okay on Cupra before, they would just need to talk to their provider to see if they would still be comfortable, I guess you're not really opting in, but non-opting out of the study. And then I'm also kind of thinking about some of those patients that have never had Keppra, and so they're not sure how they would react, and they have the SCN8A diagnosis. That might be another part of our community that might want to have that conversation with their provider on do they want to even attempt Keppra or not in an emergency type of situation, and would they want to opt out at that point? Versus the large number of us that have had Keppra, we don't want it, and most likely a lot of us are probably in that allergy or contraindicated segment of people that have that in our medical records already.
Yeah, and you're right. I mean, if its Keppra has never been tried, a good possibility is that it was already decided that Keppra is not the right drug. Now that information about Keppra and SCN8A mutation has been around for at least 8, 10 years now. And so I would guess that the physician would say, well, let's note on chart, do not use Keppra. And that would be the case. But it will be between the patient and the family and the physician. We can't decide for you. We shouldn't be deciding, but that would be my sense of that situation.
What else can we share with y'all?
I'll ask a question. So, Megan, if somebody is participating in this study, it's clear there's a lot of things that are going to be monitored. You are trying to learn as much as you can, right? Which makes sense. Does participating in this lead to any additional monitoring that may not otherwise be done in a situation? So does it, I think some people might think, oh, engage in research. Does that mean that I have to stay longer? Does that mean there's extra follow up? Can you tell us a little bit about what else is entailed in this? Or is it just like any other emergency room visit? You get your treatment, and if it works, it works. And if it doesn't, then they move on to the next treatment.
Yeah,
Right now, it's just 60 minutes. Either you're better or not when we give the drug, but we have proposed additional studies to ask. One of them is to draw blood samples, 1 or 2 blood samples after the drug is given to see how much blood drug was there
Hmm.
in the patient to just sample. So we know what is the effective concentration of the drug. And another study we've submitted to NIH, we have no idea whether they'll fund it or not, is to ask what happens 1 year and 2 years after status epilepticus. How does it affect the life of the individual who went through an episode of status epilepticus? There's a lot of anecdotal and sort of retrospective data that and that is in adults. There's that there are some long-term consequences of status epilepticus on cognition, but no prospective study has looked at it. But if that study gets approved, there'll be a whole consent process. All that testing we are proposing is from home. So nobody has to stay any day longer in the hospital, even if that study was to come to fruition. Uh, so
That's a great,
Yeah, and
yeah, that's great. Hmm.
that's such a great question, Gabby. And thanks, Judy. So for the current study, so it's the one-time dose of the study drug in the emergency department, and we collect data to see whether that worked or not. We collect data at 15 and 60 minutes after the drug was given to see if seizures have stopped and the patient's waking up, or see if seizures have continued. So that doesn't change anything with the care of the patient. That's information that we're getting from the medical team. We are also, for the study, using that EEG headband device that will be that will be placed in the emergency department. And that headband could stay on for up to 4 hours, but if it needs to be removed at any time for the patient's medical care, then that takes precedence over the EEG. So if they decide as part of the routine care that they want to get a full EEG, then the headband would come off and the hospital would place the regular EEG. And then the only other thing that happens for the study is that if the family gives their consent for the patient to continue in the study, then the research team at the hospital, that would give them permission to look at the patient's medical chart. And at the time of hospital discharge, they would collect data on how many days they were in the hospital, any adverse events that happened, a little bit more about their medical history, and background on if they've had history of epilepsy, that kind of thing. But there's no extra visits there. We don't ask anyone to come back. We're really just asking for that permission so that we can continue to access the record. And if the family decides not to continue in the research and not give the consent, then we would not collect any additional information after they've decided not to give consent for the study.
Yeah, that's great.
So there's a couple great questions in the chat. Judy, I'll let you answer
yeah,
these. So one,
other drug study. So would it interfere with other drug study? So there is one other study that is going on for emergency treatment of status epilepticus. That's a benzodiazepine dosing study called PD dose. Uh, and patients enrolled in PD dose can also be enrolled in KESETT. So it doesn't interfere with their participation. And we have had extensive talks with that PD dose study. This is for children, and we know exactly which sites that is a possibility, and we are coordinating with them. And in fact, uh, we are also making sure that when uh, patients or families are approached for consent, I mean, that's a pediatric, so parents are approached, a single person approaches them and tells them about the two studies so that it's not like you're besieged by people coming to talk to you about studies. Uh, we all agree that PD dose and KESETT don't compete and don't prevent anything, uh, uh, prevent each other from happening. PD dose is expected to end in a year and a half from now. So um, after that, should be no concern of that sort. But that's a question we always ask of every site. Is there any other study that is competing or would interfere, this would interfere with it? Because sometimes, drugs company sponsored trials are held in at sites that we may not be aware of. But we ask that question and address it. But the NIH, the federally funded uh, 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 NIH funded trials is PD-dose. So you're saying specifically drug trials, 8A has going for medications to treat A, and no, it should not. There should be no interference with ongoing 8A trials, and I mean, even if they're specific drugs, uh, this should not change anything. In case a person does get participate in KESETT and they are on a drug trial, that should not affect it because luckily Keppra doesn't interfere with the metabolism or action of other drugs. And we're giving ketamine. We know that the amount of ketamine we're giving will be out of their system within an hour or two. So, these regular medications are given once in 8 hours or 12 hours or 24 hours. So we are just trying to break the status, just like we do with benzodiazepines. We're trying to use this drug just like we use midazolam or lorazepam to break the seizures. So I don't anticipate any specific interactions or problems.
So a
Has
couple.
ketamine been mixed with phosphoretoin as a study or use? We haven't mixed it with phosphoretoin, but uh, mixing it with phenytoin may be a challenge because when you make phosphorytoin, since I've done this, you use a very high alkaline pH. It has a pH of Drano, and I don't know if ketamine would survive that kind of a pH if you mix it in the same vial. If somebody was to give it, it would be sequentially. One of the reasons why we did ESET trial was the worry that if phenytoin leaks out of the vein, it causes severe pain and necrosis, and the whole hand becomes purple. I don't know if you've ever seen those things. So it's a challenge to mix drugs with in the same vial uh, with phosphonatoin or phenytoin.
And Tammy, to your earlier comment about progressing to pentobarbital after ketamine didn't work, that would likely be a similar scenario in the study if the ketamine doesn't work. If the study drug treatment, which may or may not contain ketamine, does not work, then and the patient is still seizing, then the treating providers would proceed on to the next line of treatment, which might include something like pentobarbital.
It's an anesthetic, either pentobarb, propofol, or midazolam drip. That's what we expect to do. Sometimes pediatric hospitals try another medications. They say, "Oh, Keppra didn't work. Let me try phenytoin or valproate and see if that would work." But typical common thing is to go to an anesthetic.
A
Please.
question that I anticipate. Oh, I'm sorry. Was somebody else to talk?
No, go ahead, Gabby, please.
Okay. Another question that I anticipate might come up with some families is if they were a part of this trial, and it sounds like you're monitoring at 15 and minutes and 60 minutes. Does that mean another dose of medication would not be given until the 60-minute mark?
No,
If
if the patient has a seizure, they are instructed to treat immediately. So what we say is wait till the drug takes 5 minutes to give. It
okay,
takes for 10 minutes for it to act. So we just say wait for 10 minutes for the drug to take effect.
I see.
If after 10 minutes, that's 15-minute time mark, you observe more convulsions, we say treat, and the drug has failed.
Okay,
We,
that's a
we
great point to bring up forward, just so people know they're not. having
No,
to
no,
wait
no,
a
no.
longer
We are not
time.
observing them
Yeah,
as seizures.
thanks, Jadip. I appreciate that. Yeah, no,
No,
that's
we
really
did it
important.
Great
the same
question.
way in ESET also. We say as soon as a seizure, if we have a seizure 10 minutes after we finish giving the drug, we already know the drug has failed. We wanted the 60-minute mark is to say that drug should
Mm.
uh, uh, continue to work for at least 60 minutes before we say it's a success. Is it for subclinical status too? So that's a good question. No, we want to see explicit clinical status to treat patients. Uh, However, because we are recording EEG, we will know if the drug converts clinical status into subclinical status. This time we would know that that has happened, and that's why we are recording EEGs along with them.
Casey asked, when will the study begin and end? And do we imagine more sites coming on board later?
So the study has begun, at least technically. Uh, One site is ready to enroll, and 60 more to go for us. It's a climb. We are hoping to get most of them on board by June or July. It's a lot of hard work for Megan and Vince Cervantes, who are working diligently to get sites on board. Uh, and what happens is there's great interest in the community to participate in this trial. So Megan and Vince have a long list of waiting sites that want to participate, but we have limited funds, so we are balancing between need to bring in more and more sites versus the funding we have from NIH.
Yeah, we may bring on a few more, but the list that is there now is pretty complete.
It's pretty complete, and it won't be. Uh, we won't go to a new city. We can't afford to go to any new city outside of those hospitals. What could happen is there's a hospital and they say that we have a smaller hospital close by that can participate. Would you allow us? And we say, yeah, that's because you've already talked to the community around that hospital. It's okay to add that hospital. But if if the study is approved in Pittsburgh and you're in Allentown and nobody in Allentown reached out to the community, we won't add Allentown to the site.
And we expect our goal is to continue enrollment until 2029. But again, like Jadeep said, we have a safety monitoring board that will be regularly checking the study. And if there's any reason to stop early, we would. But to complete the study, we would continue until 2029.
And I didn't check, but I'm assuming this is a study that since it's, FDA monitoring study, it should be on clinicaltrials.gov, right? If people want to follow
Yes,
along.
it
So,
is. It is.
yeah.
It is, yeah, I can drop that link in.
Yeah, it's both FDA and NIH. So
Right. Funding. Yeah. Okay.
This is all great information. And again, just to mirror Gabi's comments of thank you for reaching out to our community and thinking of us. I know with a study like this, it's usually like, who are we going to help and how can we get as many people enrolled as possible? And you guys totally saw the flip side of this of like, what are some communities that this may not work well at all? We don't even want to have them participate. So we really appreciate you thinking of our small little community and making sure we keep our people safe.
no, I mean it's fundamental ethical responsibility
Mm,
we take on, especially in an exception from informed consent.
mm.
Uh, Engaging the community and letting everyone know uh, is the right thing to do, and that has to drive all research.
and it's an ongoing process. So this is certainly not your only opportunity to ask questions or request a bracelet. You can reach out to us anytime. You can spread the word to other people that you know, and they can contact us. And we do, of course, plan to share results with people as well. We're excited to, feels far away now, but excited to one day have results for the study. And we really hope to be able to share some important things that we've learned. And so um, please contact us anytime.
Wonderful. Thank you so much. Appreciate it. Learned a lot actually. So
Thank you.
Thank
Thank
you all for
you.
taking
Thank
the
you for taking
time.
the time to talk to us.
Yes, thank you.
And I'll be in touch with the recording and the link, and we'll go from there.
sounds great.
Sounds great.
Take care.
Bye. Thank you.